I'm going to cover in the next 12 minutes or so just what I think you should be doing for chronic rhinosinusitis patients. Most of you know a lot of this stuff. I'm just probably giving you a few tips and just reinforcing what you should be doing. So CRS is a wide condition. We see a lot of patients who get referred up with symptoms of CRS. These are two papers which have come out in the recent years about really talking about the management of CRS patients, because it's quite a heterogeneous group of patients. There's one European publication and one American publication, because Americans didn't want to feel left out, so they had to come up with their own publication in the last couple of years. Probably key when you're talking about CRS is really making the diagnosis, and you don't need a lot of equipment to make the diagnosis of CRS. It is really history-based, and that is absolutely key to CRS. So we talk about symptoms which last at least 12 weeks. And at least two of those symptoms need to be nasal obstruction or nasal discharge, and that's really important. If you don't really have nasal obstruction or nasal discharge, then it's very unlikely that you've got true chronic rhinosinusitis. Don't forget to ask about their sense of smell, okay? And that's important because if you think about the perfume industry, it's based entirely on the sense of smell. It's a key symptom for these patients, so you must ask about the sense of smell. Patients with nasal polyps often drop their sense of smell. And even if you don't have nasal polyps, as you all know, if you have a tiny cold, your sense of smell will deteriorate. So it's important to these patients. Ask about their lack of sense of smell. I've put this at the bottom intentionally. Facial pain, per se, is not a symptom of chronic rhinosinusitis. Okay? Facial pain is not a symptom of chronic rhinosinusitis. So patients who have pressure symptoms, frontal pressure, etc., that may reflect some chronic sinus disease, but acute pain, tenderness, if they walk into your surgeon, they say, my primary complaint is pain, it is very unlikely that it's going to be sinogenic in origin. Certainly not chronic sinus disease. And that's really important that that is a distinguishing factor. Okay, broadly speaking, sinusitis is defined as either having polyps or not having polyps. And we describe that as with polyps, as in CRS with polyps or CRS sans polyps. And that is a really arbitrary distinction between this really complex disease. And phenotypically, this is the way we describe them. So if you were to scan a patient who has polyps, their scans look like that. There is usually no air or very little air in their paranasal sinuses. And it's a skewed inflammatory response, usually Th2 skewed. In patients who don't have polyps, you'll get some aeration of the paranasal sinuses. And usually when you look inside the nose, if you're able to look inside the nose, you'll see some pus or mucopus inside the nose. Sinusitis is really, and if you think about it in these three ways of what the underlying pathophysiology for sinusitis is, it kind of crystallizes in your mind what you're trying to do when you're trying to treat them. So it's a combination of intrinsic mucosal inflammation, the local microbiome, and you would have heard so much about the microbiome at the moment. It's the in thing, the gut microbiome, being talked about a lot. Nasal microbiome has been focused on in the last few years, and it's a real bandwagon topic at the moment. So the local microbiome inside the nose, what is happening inside the nose? Why does it change? How does it change when you develop sinusitis? Why is it that one day you're okay, you get a viral infection, and then suddenly you trigger a whole next 15 years of chronic CRS. And then the other bit is the mucociliary dysfunction. So something happens in CRS that knocks all these three things out of kilter, and you develop chronic symptoms. Obviously, it's much more complex because there probably is some underlying hereditary causes as well. So we take the first thing, mucosal inflammation. How would we effectively reduce mucosal inflammation? Well, we all know steroids do a great job of doing this. But topical nasal steroids are the mainstay for chronic rhinosinusitis. I've used this analogy of having green on the side, which means with polyps and without polyps, that's a go. They work in, or there's effective evidence for chronic rhinosinusitis with polyps and without polyps to be managed with whatever intranasal corticosteroid you want to use. Personally, what I think you should be using is higher dose. Obviously, Butyroc is still available, but now we have Steroid, which is fully funded. So start off on at least 100 micrograms. You can always drop it if you need to. The other thing is about how long you ask them to use it for. Remember when you're getting them to use nasal steroids, 2 puffs each nostril once a day. The other thing, it's important to angle it away from the nasal septum. Right hand, left nostril, left hand, right nostril. So you're trying to avoid hitting the septum because otherwise they get nosebleeds. Flixenase is commonly associated with giving minor crusting and nosebleeds. I don't use a lot of Flixenase. Nasonex is unfortunately not available here. Let's get out of that. The other thing to remember is if you have polyps inside the nose and you're trying to get sprays inside the nose, that will have a certain effect in reducing the size of the polyps. But to really have a true effect, think about a room that's stuffed full of furniture. To actually get inside that room, you have to take out some of that furniture to make it more effective. And all the studies have shown that if you have a really congested nasal cavity or full of polyps, actually opening up the sinuses is the basic tenet of managing these patients because you can get the medication into the sinuses after you've opened them up. So great for maintenance therapy. If you're going to get them to ask them to use drops, you can draw it up in a syringe from your Butyroc bottle. It's a bit of a faff, but it does work very effectively in these patients in either the head down position. Notice the chap's got his head hanging off the end of the bed. It's not that position, it's literally the nose has to be upside down. Or the praying to Mecca position, vertex of the nose on the floor. What about prednisone? Again, prednisone is very effective in patients who have nasal polyps. Not so effective if you don't have nasal polyps. There isn't really strong evidence to support it in the use of patients without nasal polyps. How much do you give them? Okay, so 30 milligrams a day for 2 to 3 weeks is okay. Most people use it for 1 week because the maximum cumulative dose, if you look at that figure, that's a study that's come out reviewing use of steroids, is somewhere on average about 500 milligrams is what you should be tailoring towards in a year and not really more than that. So 2 to 3 courses of a year maximum. Antibiotics, so controversial when it comes to sinusitis. And every time you read a paper, there's a change in what people think about antibiotics. So I find this confusing. So I'll try and simplify it as much as I can. This is how I look at it. If you have nasal polyps, then probably using a macrolide is not the best move. It doesn't mean it's not going to have an anti-inflammatory effect, but the evidence supports using macrolide in patients that don't have nasal polyps. Okay, so if you can't see nasal polyps, it's worthwhile trying a course of macrolide therapy. How long do you try it for? Again, anywhere from 4 weeks to 12 weeks. I have to say the longest I normally use it for is probably 4 weeks maximum. These patients should normally have a normal IgE. They seem to work better if the IgE is normal and not widely raised. This is neutrophilic inflammation you're looking at. So if you do a full blood count, they don't have a raised eosinophil count. It's usually neutrophil mediated. What about doxycycline? So you notice there's just 2 antibiotics we talk about. One's a macrolide, the other is a tetracycline. Doxycycline, again, the papers vary, but they're more effective in patients with nasal polyps. So doxycycline, 3 weeks, taking 100 milligrams twice a day in patients with polyps. They're really useful in patients that have that sticky, thick mucus. When patients say that, I blow my nose and I get this thick mucus coming out, it's better in that group of patients. The next thing we talk about, if you think about it, we talk about intrinsic mucosal inflammation, then it's about the local microbiome. What about reducing the bacteria inside the nose? Does that help? Again, that's controversial because it's probably the lack of diversity in the nose that causes a problem. You have some good bacteria and some bad bacteria, and we lose the balance in CRS. So culture-directed antibiotics, I still use that. If somebody comes and they've got pus pouring out their nose and they've had an acute flare, I will take a swab and I will start them on the appropriate antibiotic. And the big problem we have at the moment is Staphylococcus. And Staphylococcus seems to be a really difficult bug to get rid of inside the nose, particularly post-surgery. So in précis of that, macrolides are good for anti-inflammatory, and usually we're talking about patients that don't have nasal polyps. Doxycycline, useful in patients that do have nasal polyps. What about topical antibiotics? It was all the rage. Remember 5 years ago, we were using it, all the rinses, using mupirocin. Mupirocin works to reduce Staphylococcus inside the nose. Unfortunately, when you stop it, it all comes back. So there's no strong evidence to stay on it long term. This is great. Improving mucociliary clearance. So easy to use, get your patients using it regularly. In both groups of patients, it works well. Lots of level 1A evidence for using irrigation rinses, whatever you want to use. It doesn't matter, whatever you want to use. Flo has some bottles that have xylitol in them, which is supposed to help with reducing that thick mucus. It doesn't really matter whichever one you use. There was a vogue for putting baby shampoo in it because some studies came out of the US saying that helped to reduce the surfactant, the stickiness inside the nose, and so you could break down the mucus. In fact, what that's shown recently is that it's ciliotoxic. So probably not use medicated things. So you can see how we go around in circles with all of this. Biologic agents are probably the most exciting development in the management of chronic rhinosinusitis. And there are a whole host of either Ig specific, IL-13 specific, or really IL-4. And the new one, which is really exciting, is dupilumab, which at the moment is used here for eczema, severe eczema. But it's or MIPO, which is the other IL-5 specific monoclonal antibody. But there was a paper just released 2 weeks ago in The Lancet. So this is a phase 3 trials, and they showed good improvement in patients that had refractory CRS with nasal polyps. And the interesting thing about this drug is it gives them back their sense of smell within 5 days. So it's fantastic in patients like this. Unfortunately, it's $43,000 a year. And if you stop it, all the symptoms come back. So exciting as it is, we'll have to wait for the prices to come down. But it's a bit like saying take your nasal steroids long term. These things are long-term medications. A chronic disease, you're not going to change chronicity. Just very briefly, aspirin desensitization. If your patients come in, you're taking your history, and they've developed adult onset asthma, they're aspirin sensitive, think about desensitization. There's good evidence that desensitization works, and you don't have to be on massive doses. This group of patients that have polyps, asthma, and aspirin sensitivity, we call them aspirin-exacerbated respiratory disease or Samter's triad. So they can be on low doses of aspirin long-term. As low as only 100 milligrams will be enough to desensitize them. You just got to look out for GI side effects. But on that low dose, they're usually well tolerated. So here are 4 different types of drugs that might be used in CRS patients. Some of them are really very limited benefit. Claritin, or an antihistamine that I've put up there just for the purposes of a antihistamine, it's not one that I particularly like, is useful if your patients have atopy as well. So it's not going to treat your chronic rhinosinusitis, but it's useful because many patients do have concurrent atopy as well. Probably the one that we held out most promise for was an anti-leukotriene or Singulair Montelukast, and in a small group of patients that will work well. But I usually use it in conjunction with the immunotherapists or respiratory physicians. If they fail medical therapy, of course, you talk about surgery because that does help to deliver the medical therapy. This is just a very quick, interesting paper that came out a few years ago. And what they found was if you kept patients on CRS therapy, or you didn't manage to control their CRS symptoms, many of them went on to develop asthma. And I think that's a really important point because it suddenly made a snotty nose interesting and sexy to public health funding, because if you could treat CRS early, the risk of developing asthma dropped. And the other thing is their outcomes are much better. So if you let them on the NHS, patients were languishing for 2 years with CRS symptoms. Their outcomes compared to those patients that were treated early were much worse long term. That's because you get bony changes, underlying bony changes, which are really difficult to reverse. So the key points. Making your diagnosis is based not on some fancy investigations, but taking a concise and accurate history. Facial pain does not point towards CRS. Think about nasal obstruction and nasal discharge. Intranasal corticosteroids are your mainstay of treatment. Go for a higher dose for a minimum of 2 months treatment. Minimum of 2 months. Remember to direct it outwards. Saline rinses, they should all be taking saline rinses. Okay, if they have symptoms of CRS, we know that this is useful to get rid of the mucus. Antibiotics, I'll leave it up to you. They don't have to take antibiotics. It's worth the trial of antibiotics before you refer them in. If they've got polyps, doxycycline. If they haven't, try macrolide therapy. Prednisone, useful in those patients that have polyps. Give them 30 milligrams for a week, just stat. You can always tailor it down over 3 weeks. Surgery is really useful for those patients that fail therapy, or if they're stuffed full of polyps, nothing's going to get through. Remember, all patients, right at the outset when you see them, the conversation to have with them is, this is a long-term problem. They'll need maintenance therapy with a topical nasal steroid long-term in both groups.